Right now, I'd like to introduce to you our first speaker, uh, Dr. Satya Das. Dr. Das is an assistant professor of medicine at Vanderbilt University Medical Center. His research interests lie in phase 1 GI cancer research, including NETs. He also leads the neuroendocrine tumor program at Vanderbilt, and it's my great pleasure to introduce to you Dr. Das. Welcome.
Bob, thank you for such a kind introduction. Really a pleasure to be here today and speaking at the NCAN Patient Conference, and thrilled to be here with my colleagues. So my topic that I was tasked to talk about is current treatments and clinical trials for patients with neuroendocrine tumors. These are my disclosures. The main one that I wanted to focus on is that I'll primarily be discussing clinical trials that are open in the United States, in part or in totality during this talk. So with regards to a roadmap to the talk, what I wanted to focus on are current treatments for patients based upon the heterogeneity of neuroendocrine tumors, meaning the variance by primary tumor site, tumor grade, and somatostatin receptor expression. I then wanted to shift gears to ongoing or soon-to-be activated clinical trials for patients with well-differentiated neuroendocrine tumors. And then I wanted to finish the talk by talking on ongoing or soon-to-be activated clinical trials for poorly differentiated neuroendocrine carcinomas. Just a brief mention of the figures on the right. The field of neuroendocrine cancer has transformed in a massive way over the last 100 years, starting from the first pathologist to diagnose neuroendocrine tumors, Siegfried Oberndorfer, who's the gentleman on the top left, to Dr. Charles Mortel at the Mayo Clinic, who was one of the first clinicians to study them. I think we've made a lot of progress. However, there's certainly room to go. So with regards to treatment approaches for patients with neuroendocrine tumors, the name of the game is that it varies, and each patient's cancer is individual. We know that treatments vary depending on the primary tumor location, and we'll touch on that in the next few slides. It varies depending on the grade of a tumor or how a tumor looks under the microscope. It varies depending upon the receptor expression, and the receptor that I'm talking about here is somatostatin receptor that is expressed on a tumor. Treatment approaches vary depending on the extent of a patient's tumor burden, how quickly the disease is changing, and what kind of symptoms the tumor is causing. And finally, treatments vary depending on the hormonal activity of tumors. On the diagram on the right, we just see a distribution of how neuroendocrine tumor primary sites are distributed. The small bowel is oftentimes the most common site, followed by lung neuroendocrine tumors. And we see other neuroendocrine tumors in areas such as the pancreas, rectum, and colon, as well as in rarer sites. So classification system and how we think about neuroendocrine tumor grade is significant and actually has changed over the last several years. So previously, any tumor that was not considered grade 1 or grade 2, and we define grade here by mitoses and something called the Ki-67 index, which is a measure by which we look at how quickly neuroendocrine cells divide under the microscope. And every grade 3 tumor used to be considered poorly differentiated. However, that has now changed. We now recognize that there's an entity of tumors that are grade 3 neuroendocrine tumors that are well differentiated and can behave more indolently. However, with regards to poorly differentiated neuroendocrine cancers, we still think of these tumors being defined in a few different types. They can be small cell types, they can be large cell types, or they can be mixed histologies. However, we do think of poorly differentiated neuroendocrine carcinomas as sort of a uniform disease entity. So with regards to some of the currently available treatments for patients with well-differentiated neuroendocrine tumors, we can think about different classes of agents. So this is a diagram taken from a paper some time ago, but I think it really depicts what some of the pathways are and what we're trying to target. So the first class of agents that I want to touch on are somatostatin analogs. Now, 90 to 95% of low-grade neuroendocrine tumors or well-differentiated neuroendocrine tumors express somatostatin receptor, and the most common receptor is somatostatin receptor 2. So we know that the drugs that target this receptor include octreotide, lanreotide, and on an experimental level, a drug called pasireotide. Now, what these drugs do is they bind the receptor and actually turn off cellular growth. And we can see on the diagram there, by blocking the somatostatin receptor, cell cycle activation and cell growth is turned off. Another common class of agents are the mTOR agents. One of the common agents that's FDA approved is called everolimus. Everolimus blocks a pathway called PI3 and the mTOR pathway. This is an essential pathway for protein synthesis, cell growth, and actually blood vessel formation of neuroendocrine tumors. Another common class of agents for well-differentiated neuroendocrine tumor patients is called sunitinib, which is a antivascular blood vessel growth factor-directed agent. And VEGF is what we call upstream or ahead of some of the growth-forming pathways. So by blocking vascular endothelial growth factor, we effectively reduce blood vessel growth, but also turn off cell progression and neuroendocrine tumor growth. So these are some of the common classes of agents and the pathways that are affected. So Dr. Chauhan will be talking about peptide receptor radionuclide therapy and updates. However, I think it is important to think about this therapy in a schematic way. So PRRT, very simply, is a lock and key-based therapy. Here, the lock is somatostatin receptor 2, which is expressed in most well-differentiated NETs, and the key is a peptide here, which can either be an analog of somatostatin or an antagonist that is linked to a particle that elicits or secretes a radionuclide, which creates cell death. The radionuclide that's FDA approved in the United States is called lutetium-177, and that therapy is called Lutathera. Now, there are a variety of different radionuclides that are being studied that are looking to build upon the activity of PRRT, and those are some things that we'll touch on a little bit later in the available clinical trials, but also some of the aspects that Dr. Chauhan will discuss in detail. So with regards to some of the data for the currently available landscapes, I wanted to make a table to sort of kind of give a view of some of the treatments we have and the data behind them. So the first class of agents that I wanted to focus on were octreotide and lanreotide. So octreotide was first tested in the PROMID study. This was a study that was in actually midgut or small bowel neuroendocrine tumor patients that had carcinoid syndrome, and patients got octreotide or placebo. And the primary endpoint of this study was time to tumor growth. And what you can see here is that octreotide reduced time to tumor growth by about 60%. Lanreotide was tested later in patients with neuroendocrine tumors that were non-functional. And again, the primary endpoint of the study was time to tumor growth. And lanreotide also slowed tumor growth by about 50 to 55%. What's important to note is that the response rate denoted here by overall response rate was only 2 to 3%, meaning that these therapies are great for freezing tumors, but they're not so great for shrinking tumors in a massive way. The next class of agent that we touched on prior was everolimus, and this was tested in 2 studies. The first was the RADIANT-3 trial, which was in pancreatic neuroendocrine tumor patients that had grown through a somatostatin analog. And the second trial was the RADIANT-4, which was in lung and small bowel neuroendocrine tumor patients that had grown through a somatostatin analog. And again, both of these studies were placebo-controlled, and we'll touch on that a little bit later, why previous studies were placebo-controlled, and today's studies are moving away from that. But what you can see again is that everolimus slowed tumor growth by about 50 to 60%. However, the tumor shrinkage was very modest again at 2 to 5%. Sunitinib was tested in patients with progressive pancreatic neuroendocrine tumors, again in a placebo-controlled study, and it slowed tumor growth by about 60%. The shrinkage with sunitinib, though, in pancreatic neuroendocrine tumors was a little bit better at close to 10%. And finally, the NETTER-1 study, which is the study that got lutetium dotatate approved, was conducted in small bowel neuroendocrine tumor patients. It was not a placebo-controlled study, and it randomized patients to PRRT or a higher dose of octreotide. And the primary endpoint of slowing tumor growth was met. PRRT reduced tumor growth by almost 80%. And what was also striking was it caused tumor shrinkage in about 20% of cases. So, talking a little bit about treatment approaches, or how I think about treating a patient with a grade 1 or grade 2 well-differentiated gastrointestinal neuroendocrine tumor, the first thing I think about is somatostatin receptor expression. So, if a patient has somatostatin receptor expression positivity denoted by a dotatate scan, whether that's a curium scan or a gallium scan, the first line treatment is typically a somatostatin analog. Upon progression, one can think about PRRT, one can think about everolimus, or one could think about clinical trials. For a patient without somatostatin receptor positivity, the options are a bit more limited, but everolimus is certainly an option, and clinical trials are an option. The way I think about treating patients with grade 1 and grade 2 well-differentiated pancreatic NETs is also as follows. The first thing I just want to point your attention to is looking at the slide. There are more treatment options that you guys can see. There are more FDA-approved treatment options for pancreatic neuroendocrine tumors compared to any other actually neuroendocrine tumor. So again, for patients with somatostatin receptor positive disease, one can think about a somatostatin analog. If patients have bulkier disease, oftentimes they start with capecitabine and temozolomide, which is a chemotherapy that helps shrink the tumors. And then in the later line setting, we think about things like PRRT, we think about things like everolimus, sunitinib, or a clinical trial. Here, for patients with somatostatin receptor negative disease, the only options that typically are not on the table are the somatostatin analogs or PRRT. Now, the question of sequencing of PRRT is a very important one. When do we sequence it? Do we wait till after progression on certain therapies or not? Now, some of the trials I'll touch on are seeking to answer this question, but this is some of the work that we've done recently. We actually looked at patients first at Vanderbilt who were being considered for PRRT and gave them a score. We scored these patients based on their tumor bulk, the prior treatments they've gotten, where their tumor came from, and we came up with a score on a scale from 0 to 9. What we can see on the diagram on the left, in the light green, is patients with lower scores who got PRRT actually did the best. And what this suggests to us as a field is perhaps earlier incorporation of PRRT may be better, and lutetium may work better when tumors are smaller. Now, this is something that still needs to be validated, and Dr. Chauhan and I and Dr. Ramirez actually have some data showing that this score does persist when we look at other sites, and it may be something that we look about incorporating PRRT on a sooner level. So with regards to treating patients with well-differentiated grade 3 gastroenteropancreatic NETs, it is a little bit trickier. One of the main stratifying factors I use is based on whether somatostatin receptor expression is present, and also the Ki-67 index of a tumor. So if the Ki-67 index of a patient's tumor is less than 55%, and the tumor is behaving like a more indolent, well-differentiated neuroendocrine tumor, I think about all the options that we previously talked about, from a somatostatin analog, capecitabine and temozolomide, to potentially PRRT. There may be a role for immunotherapy, and we'll touch on that in the next slide. But that's the way I think about it for patients with the Ki-67 of less than 55%. For patients with tumors with Ki-67 greater than 55%, we think about these tumors as behaving a little bit more aggressively. And some of the studies looking at PRRT have shown it to be less effective in this subgroup. So we think about chemotherapy, such as capecitabine and temozolomide, FOLFOX, platinum chemotherapy, immunotherapy or trials being more relevant in this patient population. So with regards to treatment options for patients with poorly differentiated neuroendocrine carcinomas, the first line treatment standard is platinum doublet chemotherapy, so carboplatin or cisplatin and etoposide. What we see on the diagram on the left is actually there's no difference between using carboplatin and cisplatin in patients with unremovable neuroendocrine carcinoma. Unfortunately, the survival rates are still quite dismal, and we have a lot of work to do. Median survival times for patients with these diseases are oftentimes 12 to 18 months from historical studies. In the later line settings, we do have certain chemotherapies like topotecan or FOLFOX, but what we can see from our Kaplan-Meier curves or the time to tumor growth curves is that for both time to tumor growth and overall survival, topotecan's time to tumor growth is only about 2 to 3 months, and survival times of about 4 to 5 months. And FOLFOX's time to tumor growth is only about 5 to 6 months, and survival times of 8 to 10 months, really sort of demonstrating that we have a lot of work to do for poorly differentiated neuroendocrine cancers to get better treatments. So the way I think about treating patients with poorly differentiated neuroendocrine carcinomas is starting with platinum doublet chemotherapy, and either upon progression or response, thinking about early incorporation of clinical trials or other options such as immunotherapy or chemotherapy. So with regards to immunotherapy, this is still a hotly debated area. We know that immunotherapy doesn't typically work for grade 1 and grade 2 neuroendocrine tumors, particularly those that don't have certain features that suggest immunotherapy response. But we do know that the data suggests that there is some activity in either grade 3 tumors or poorly differentiated neuroendocrine carcinomas. So on the diagram on the left is what we call a waterfall plot that's actually looking at tumor shrinkage. Any shrinkage below that line on the bottom, which is at about 30%, is what we consider meaningful shrinkage. And on the left is from a study in poorly differentiated neuroendocrine carcinomas, and about 50% of patients had tumor shrinkage, which was quite striking. Now, this still needs to be studied in bigger trials, but this is ongoing. On the right, we see the same waterfall plot in a mixed crowd of neuroendocrine tumor patients. So those with grade 3 neuroendocrine tumors, those with atypical lung neuroendocrine tumors. And what we actually see is that the combination of nivolumab and ipilimumab actually had activity in patients with potentially grade 3 NETs or even atypical lung NETs, but an area of research that still needs to be defined. So with regards to the current landscape of NET clinical trials, what you guys will see is that for well-differentiated neuroendocrine tumors, PRRT very much dominates the treatment landscape. But as we go to neuroendocrine carcinomas, other options like chemotherapy and other aspects come to fruition. And I should mention that beyond treatment itself, there are other types of studies for patients with well-differentiated neuroendocrine tumors, particularly those with debilitating diarrhea. So both myself and Dr. Chauhan have different studies of Enterade, a medical food that can reduce diarrhea burden and improve GI symptoms. So there are different trials beyond the therapeutic studies that I will be talking about. So with regards to clinical trial phases, we think about a phase 1 study being dedicated to patient safety, a phase 2 study being dedicated to effectiveness or demonstrating the activity of the drug, and a phase 3 study typically being compared to the best prior standard to get a drug approved. So with regards to our trials for patients with well-differentiated NETs, the first study I wanted to focus on is a PRRT sequencing study called the NETTER-2 study. This is a global study which is going on in the US. Patients with more aggressive grade 2 and grade 3 neuroendocrine tumors are randomized here to 4 cycles of lutetium dotatate plus octreotide or 60 milligrams of octreotide monthly. The primary endpoint of this study is time to tumor growth, with secondary endpoints of tumor shrinkage and survival. The main question this study is seeking to answer is that should PRRT come first as a treatment for patients with more aggressive neuroendocrine tumors? The next study that I wanted to touch on, looking at sequencing PRRT, is the COMPETE study. So this is a study that's looking at somatostatin receptor patients with gastroenteropancreatic neuroendocrine tumors and is randomizing patients in a 2-to-1 fashion to lutetium edoreatide, which is a slightly different version of PRRT, versus everolimus. The primary endpoint is time to tumor growth, with secondary endpoints of tumor response. The main question that this study is seeking to ask is, should PRRT be given before everolimus in patients with well-differentiated GEP-NETs? And the second and equally interesting question is that, is giving a somatostatin analog with PRRT actually necessary? With regards to a new indication for PRRT that's possibly being explored is the study NCT 5739. This is a soon-to-be activated study in the United States that's looking at patients with lung neuroendocrine tumors that have somatostatin receptor positivity and is randomizing them to 4 cycles of lutetium dotatate or everolimus. The primary endpoint of this study is time to tumor growth. The main question that this study is seeking to answer is that, is PRRT more effective than everolimus in patients with lung NETs? And secondly, as you all know, PRRT is not yet FDA approved or approved in Europe for patients with lung neuroendocrine tumors, despite there being evidence in smaller studies that PRRT is active. So we are hopeful that if this study is positive, that it can lend the evidence to the FDA to get PRRT approved for this group of patients. With regards to combinations, and these are aspects that Dr. Chauhan will also touch on, but the combinations that I really wanted to touch on briefly are combining PRRT with what we call DNA damage repair inhibitors. PRRT works by damaging DNA of cancer cells, and other agents that can block the repair of the damage created by PRRT would be presumed to be highly effective. So some of these include Dr. Chauhan's study of triapine, which is an ongoing phase 1 study. We have a study that Dr. Del Riviero is leading with the PARP inhibitor olaparib that will soon to begin approval. And another study is with another class of DNA damaging agents called DNA PK inhibitors that Dr. Chauhan will be leading, and that will be open to activation soon. But the main questions that these studies are seeking to answer is that will the addition of DNA damage repair inhibitors to lutetium dotatate be safe? With regards to new PRRT agents, there's an ongoing study of lead dotamtate, which is an alpha-emitting agent. This is a study that's ongoing and being led by Dr. Del Passand. This is a study of actually in patients with any somatostatin receptor-positive neuroendocrine tumors. Patients would get 3 cycles of the lead dotamtate, and the primary endpoint of this study is safety, to make sure that it's safe, and the secondary endpoints include looking at tumor shrinkage. So the main question that this study is seeking to answer beyond safety is that what is the activity of alpha emitters in patients who are PRRT naive? Some of the prior studies have looked at alpha emitters in patients who've already progressed on lutetium dotatate or beta emitters, but this study will give a baseline of the activity in the treatment naive setting. With regards to tyrosine kinase inhibitors, a drug that's being tested in the CABINET study is called Cabozantinib. This blocks blood vessel growth as well as other receptors. The CABINET study is a registration study, meaning that if it is positive, it will likely lead to approval for this agent. This is a study in pancreatic neuroendocrine tumors and extrapancreatic neuroendocrine tumors who are randomized in a 2-to-1 fashion to Cabozantinib or placebo. The primary endpoint of the study is time to tumor growth. Some significant changes have been made to the study to allow it to become more alluring to patients to accrue. So everolimus is no longer mandated for patients to have gotten the agent or progressed on it. And now crossover is allowed, meaning patients who get the placebo would now have the option of getting cabozantinib upon tumor growth. One of the other exciting tyrosine kinase inhibitor combination studies is NCT 9757. This is a study that is combining a new anti-blood vessel agent called surufatinib with a new checkpoint inhibitor called tislelizumab. This is a global study which is also open in the United States, and it'll be open actually at our center at Vanderbilt quite soon. The safety of this combination has been shown, and now we are moving to the phase 2 efficacy portions. There are 2 NET cohorts, those with GEP nets, grade 1-2 GEP nets, or those with typical or atypical bronchial nets. And the primary endpoint of the phase 2 portion is to look at tumor shrinkage. So the main questions that this study are seeking to answer is that, will this combination be safe for patients? And actually, more importantly, will this combination unleash the activity of immunotherapy for patients with grade 1 and grade 2 neuroendocrine tumors, a population in which immunotherapy has not been shown to be active thus far? With regards to ongoing trials for patients with poorly differentiated neuroendocrine carcinomas, the first study that I wanted to focus on was the ECOG-ACRIN 2142 study. This is a study that actually just closed quite recently, and study results are pending. But this was a study that looked at grade 3 neuroendocrine tumor patients, those with both well-differentiated grade 3s as well as poorly differentiated neuroendocrine carcinoma, as long as they did not have a small cell type. And patients were randomized to the oral regimen of capecitabine and temozolomide or IV chemotherapy with platinum-based chemotherapy. The primary endpoint of this study was time to tumor growth, and secondary endpoints were tumor shrinkage and survival. The main questions that this study was seeking to answer is that for patients with grade 3 neuroendocrine neoplasms, is the IV regimen better or CAPE-TEM better? And perhaps as equally importantly, do patients with poorly differentiated neuroendocrine carcinomas preferentially benefit from platinum chemotherapy, and do well-differentiated grade 3 tumor patients benefit from capecitabine and temozolomide? So these answers are still pending. This is a study, NCT 4497, combining chemotherapy with DNA damage repair inhibitors. This is a study that I've been fortunate to be involved with. And this is a study that is looking at a new type of DNA damage inhibitor called ATR inhibitors. And we are combining that with known chemotherapy, irinotecan or topotecan. Once safety has been established, we will then be testing it, the combination of the ATR inhibitor plus topotecan in patients with small cell lung cancer and poorly differentiated neuroendocrine carcinoma. The main questions that we are seeking to answer here is that, will these combinations be safe? And can we predict and find the patients who will benefit from these combinations selectively? And the final study that I wanted to touch on before offering up a few summarizing thoughts is a combination immunotherapy study. So this is NCT 9712. This is an NCI-sponsored study that's ongoing in multiple centers around the country. And this is a study looking at patients with any poorly differentiated neuroendocrine carcinoma who've grown on one prior line of therapy, and treating all patients with nivolumab, ipilimumab, and that tyrosine kinase inhibitor, cabozantinib. After several cycles, the ipilimumab is dropped, and patients continue on nivolumab and the cabozantinib alone. The primary endpoint of this study is tumor shrinkage. We are approaching the first assessment for this study, and we'll see if this combination is indeed active. So the main question that is being answered and asked rather by this study is that, does combined immunotherapy have a role for patients with poorly differentiated neuroendocrine carcinoma? And can cabozantinib further unleash the activity of these drugs in this patient population? So with regards to a few of my summarizing thoughts with regards to subsequent clinical trials, I think we really need to think about what is the best way to build upon the activity of PRRT with lutetium dotatate. Is this through new combinations, some of the ones we talked about, like DNA damage repair inhibitors, or combinations with tyrosine kinase inhibitors? Where do alpha emitters fit in? Do they fit in only after patients have failed the therapy? The therapy rather has failed patients, or do we give it up front before patients get exposed to lutetium dotatate? With regards to immunotherapy, does immunotherapy only work for patients with poorly differentiated neuroendocrine carcinomas? Or does immunotherapy, can we unleash its activity for patients with lower grade tumors with certain agents like surufatinib? The big questions that are on all our minds are, how do we sequence later line treatments for patients with poorly differentiated neuroendocrine tumors? We now have a number of agents that are being combined. We now have a number of chemotherapies that are being looked at, but how do we know which one is better? And beyond better, how do we define better? Is it just based on activity for patients, or is it based on tolerability and toxicity? So how do we look at new endpoints and new drugs that are not just active but also tolerable for patients with poorly differentiated neuroendocrine carcinomas? And I think one of the other big questions that we're all thinking about is, where does the role of surgical debulking fit in for patients? Can we combine surgery with different modalities such as PRRT to improve effectiveness? In fact, one of the studies that we are proposing is actually looking at surgery prior to PRRT to remove bulky or big tumors to enhance the effectiveness of PRRT. So I think these are some of the questions that are on the treatment landscape and on the minds of investigators, looking at these questions. And I think we have to be very thoughtful about making sure that these trials improve quality and quantity of life for patients. But it's a very exciting period. So I thank you for your kind attention, and we'll be happy to take questions in the Q&A session later on. Thank you.